Good morning for all of you on the West Coast and afternoon for the East Coasters. My name is Jenna Giannato, and I'm a clinical pharmacist with Avella Specialty Pharmacy. I work with the oncology team here at our national distribution facility located in Phoenix, Arizona. And today I'm going to be discussing the article that was published this summer in the New England Journal of Medicine titled Enzalutamide in Metastatic Prostate Cancer Before Chemotherapy, otherwise known as the PREVAIL trial. You will be able to submit any questions you may have using the tool within the webinar, and I will address those at the end of the presentation. Just to start with the disclaimer, the information is for educational purposes only and is not intended to substitute for the medical judgment of the healthcare provider. Recommendations for the use of any particular therapeutic agents or methods are based upon the best available scientific evidence and guidelines. Reference in this activity to any specific commercial products, process, service, manufacturer, or company does not constitute its endorsement or recommendation. Off-label use of therapeutic agents will be discussed. I am a compensated Avella employee. Okay, so first of all, getting started, I'm looking at the current therapies for prostate cancer. Today we will be focusing on anti-androgens and targeted therapy, specifically enzalutamide and Zytiga with prednisone. Starting with Zytiga, the mechanism of action is a selective and irreversible inhibitor of CYP17. This is an enzyme required for androgen biosynthesis and is expressed in testicular, adrenal, and prostatic tumor tissues. It inhibits two precursors to testosterone, one of which being DHEA. It's the first oral agent that was approved for metastatic castration-resistant prostate cancer, first as second line in 2011, and then it received the first line indication in December of 2012. For administration and dosage, Zytiga is taken as 4 250 milligram tablets once a day on an empty stomach, taken in combination with prednisone 5 milligrams twice a day. Increased mineralocorticoid production by the adrenals due to increased levels of steroids warrant the use of prednisone with this medication. Common adverse drug events that we see are diarrhea in about 17.6% of patients, all grades, with only 0.6% being grade 3 or 4. 26.7% of patients experience edema, 29.5% experience joint swelling or discomfort, and 19% experience hot flush. These patients will also potentially show nocturia and urinary tract infection. And looking at the pharmacokinetics for Zytiga, the absorption, the systemic exposure is increased when taken with food, which is why we have patients take on an empty stomach, and the time to peak is about 2 hours. When looking at distribution, it's 99% protein bound to albumin and alpha-1 acid glycoprotein. It's metabolized via CYP3A4 to an active metabolite and has a terminal half-life of 14.4 to 16.5 hours. Moderate hepatic impairment may warrant dose decrease to 250 milligrams by mouth once daily, and you want to avoid Zytiga in severe hepatic impairment. The study that helped first-line indication for this medication was abiraterone in metastatic prostate cancer without previous chemotherapy. It showed improved radiographic progression-free survival and improved overall survival. It significantly delayed clinical decline and initiation of chemotherapy, and the median radiographic progression-free survival was 16.5 months with the treatment group and 8.3 months with the prednisone alone. The safety profile was similar to what was previously reported. Now moving on to looking at Xtandi, the mechanism of action is it's an androgen receptor inhibitor that competitively inhibits androgen binding to receptors and inhibits androgen receptor nuclear translocation and interaction with DNA. This leads to decreased proliferation and cell death of prostate cancer cells in vitro. The current indication is for the treatment of metastatic castration-resistant prostate cancer for patients who have previously received docetaxel. Looking at dosage and administration, patients will take 4 40-milligram capsules by mouth once daily. It's administered with or without food. No initial dosage adjustments for mild to moderate renal or hepatic impairment is necessary. It can be stored at room temperature, but the gel-filled capsules may warrant seasonal cold chain shipment. Looking at pharmacokinetics for the absorption, the AUC is not altered when administered with a high-fat meal, which is why patients can take this with or without food. Steady state is achieved by day 28, and the time to peak after oral administration is 1 hour. This medication is 97 to 98% protein bound and is metabolized by CYP2C8 and 3A4. The terminal half-life for enzalutamide is 5.8 days for the active metabolite, and the active metabolite's half-life is 7.8 to 8.6 days. For common adverse drug events that we see, 50.6% of patients have asthenic conditions, with 9% of those being grade 3 or 4. We see diarrhea in 21.8% of patients, hot flush in 20.3%, hypertension in 6.4% of patients, with 2.1% of those being grade 3 or 4, and edema in 15.4%. Dizziness, insomnia, and anxiety are also seen. Warnings include patients with a history of predisposition to seizures. In the clinical trial, 0.9% of patients in the Xtandi treatment group experienced a seizure. We also see the fertility warning, but in this population, the average age at diagnosis is about 66. As I mentioned previously, Xtandi is metabolized via CYP2C8 and 3A4. Based on in vivo and in vitro data, CYP2C8 is primarily responsible for the formation of the active metabolite. When looking at administering this medication with strong or moderate inducers of either 2C8 or 3A4, it's important to note that the plasma concentration of enzalutamide may be decreased. Also, strong or moderate inhibitors of either 2C8 or 3A4 may increase plasma concentrations and increase risk for toxicity. So some examples for the 3A4 inducers would be carbamazepine or phenytoin, and for the inhibitors, itraconazole. For 2C8, we see inducers being rifampin or inhibitors being gemcitabine. Now moving on to the journal article. This trial was a double-blind, randomized, placebo-controlled phase 3 trial that enrolled patients from September 2010 to September 2012. 1,717 patients were enrolled in the study, and they utilized 207 sites globally. For the trial, the co-primary endpoints included radiographic progression-free survival and overall survival. Radiographic disease was evaluated with the use of either CT or MRI and with the use of bone scanning. The imaging was performed at the time of screening at weeks 9, 17, 25, and every 12 weeks thereafter. Secondary endpoints included time until initiation of cytotoxic chemotherapy, time until the first skeletal-related event, best overall soft tissue response, time until PSA progression, and decline in PSA of 50% or more from baseline. Centralized radiologists who are unaware of the study group assignments determined whether there was progressive disease based on the RECIST version 1.1 for soft tissue. This stands for Response Evaluation Criteria in Solid Tumors. They also used criteria adapted from the Prostate Cancer Clinical Trials Working Group 2 for bone disease. RECIST defines complete response, partial response, progressive disease, and stable disease in its criteria. The study also had some exploratory endpoints that they looked at, one of which was the patient's quality of life, and for that they used the FACT-P scale. They also looked at decline in PSA level of 90% or more from baseline. FACT-P is a quality of life instrument that is specifically designed for prostate cancer patients. It has 27 core items which assess patient function in 4 domains: physical, social and family, emotional, and functional well-being. Each item is rated on a 0 to 4 Likert type scale, with a higher score meaning a better quality of life. Looking at the statistical analysis, the estimated goal for enrollment was about 1,680 patients. As you saw on the previous slide, they enrolled over 1,700 patients. The co-primary endpoints were analyzed in the intention to treat population with a total type 1 error rate of 0.05. Just to point out, intention to treat includes in the analysis all patients whether or not they finished the study, and type 1 error is the incorrect rejection of a true null hypothesis. Secondary endpoints were analyzed using Holmes' step-down procedure, which is a method used to counteract the problem of having multiple comparisons. Looking at the participants of the study, with the eligibility criteria, patients needed to have histologically or cytologically confirmed adenocarcinoma of the prostate with documented metastases, PSA and/or radiographic progression in bone or soft tissue despite receiving LH-RH analog therapy or undergoing orchiectomy with serum testosterone level of 50 nanogram per deciliter or less. We also wanted continued androgen deprivation therapy to be required. Also, no previous cytotoxic chemotherapy, ketoconazole, or Zytiga. They also wanted the patients to have an Eastern Cooperative Oncology Group performance status of grade 0 or 1. Status of 0 means that the patient is fully active, and 1 is restricted in strenuous activity but ambulatory and can carry out work of light nature. These scales and criteria are used to assess how the patient's disease is progressing. Lastly, they wanted the patients to have either asymptomatic or mildly symptomatic as per the brief pain inventory short form question number 3. It is important to point out that the baseline demographic and disease characteristics were well balanced between the 2 groups, and the exclusion criteria included patients with a history of seizure or condition that could confer a predisposition to seizure. Treatment continued until toxicity or confirmed radiographic progression and initiation of chemotherapy or study agent. Looking at the results, the first figure showing Kaplan-Meier estimates for the co-primary endpoints of radiographic progression-free survival in panel A and overall survival in panel B. The dashed horizontal line indicates the medians. Looking specifically at panel A, at 12 months, progression-free survival was 65% for the enzalutamide group and 14% in the placebo group. This showed an 81% risk reduction of radiographic progression or death, which had a significant p-value of less than 0.001. For figure B, with overall survival, treatment with enzalutamide as compared with placebo resulted in a 29% decrease in the risk of death. This also showed a significant p-value, which was less than 0.001. The median time that patients received a study drug was substantially longer in the enzalutamide group versus the placebo. It was 16.6 months versus 4.6 months in the placebo group. It is important to point out that after review of the interim co-primary endpoints and safety data, the monitoring committee recommended that enzalutamide be offered to eligible patients receiving placebo. Looking at the secondary and pre-specified exploratory endpoints, you can see here that the median time until the decline in FACT-P scale was statistically significant in the enzalutamide group versus the placebo. A decline in FACT-P was defined as a decrease of 10 points or more on the global scale, which include scoring from 0 to 156. The first skeletal-related event occurred in 32% of the treatment group and 37% of the placebo group. PSA progression was based on criteria of the Prostate Cancer Clinical Trials Working Group 2, and PSA progression was 11.2 months in the treatment group and 2.8 months in the placebo group, also showing significant p-value. Only patients with baseline and post-baseline assessments are included in this chart, and soft tissue disease was assessed based on the response evaluation criteria in solid tumors version 1.1. This next figure represents another Kaplan-Meier estimate, this time looking at cytotoxic chemotherapy and increased level of PSA. For figure A, the results for median time until initial cytotoxic chemotherapy were 28 months in the enzalutamide group and 10.8 months in the placebo group, which also showed a significant p-value of less than 0.001. And then figure B shows the median time until PSA progression, which is 3 months in the placebo group and about 11 months in the enzalutamide group. Also significant p-value here. Included in this category are ABEs that were reported in at least 10% of patients in the treatment group at a rate that was at least 2 percentage points higher than the placebo. Similar ABEs previously reported on the label included diarrhea, hot flash, hypertension, back pain, and falls. Please note that this seizure occurred after the data cutoff time. So I'm looking at the clinical significance. Enzalutamide is an option for patients with metastatic prostate cancer prior to chemotherapy use. It's a good option for patients who cannot handle chemotherapy, and the safety profile was similar to what was previously reported. It significantly delayed radiographic disease progression or death, the need for cytotoxic chemotherapy, and the deterioration in quality of life. It also significantly improved overall survival. It's important to point out that this is currently not indicated for first-line treatment as Zytiga plus prednisone is. Changing gears a bit, I wanted to take a minute to point out the difference of using a specialty pharmacy versus a retail pharmacy for your Xtandi and Zytiga patients. Specialty pharmacy proactively works on patient care, having access to limited distribution medications, using high-touch clinical support and knowledge, and availability of clinical staff around the clock. We also utilize adherence tools and work diligently on obtaining prior authorizations and financial assistance for patients. Looking at the path of a specialty pharmacy prescription versus a retail claim, you see on the right side, it shows a retail prescription where the patient brings the prescription and it's filled and the patient picks it up, versus the situation of a specialty pharmacy where the prescription is received, pharmacy contacts the provider to confirm that we received the prescription and begins processing the script, then benefits investigation, where we gather patients' clinical and insurance information and may be triaged due to insurance requirements or may require a prior authorization. Specialty care coordinators work with payers to obtain prior authorization, which is often required for these medications. If the PA is not approved, Avella will work with the office on an appeal on behalf of the patient, and then we also may help the patient obtain financial assistance by working with numerous funding organizations. Okay, so we have had a few questions submitted. First of all, address the first one that I received, which was why was a secondary endpoint related to skeletal events? So the reason for that is the androgen deprivation therapy can put a patient at risk for skeletal-related events such as fracture. Also, skeletal morbidity can present in these patients due to bone metastases. We also received a question on the brief pain inventory short form question 3, asking what the question entailed. The question said, please rate your pain by circling the one number that best describes your pain at its worst in the last 24 hours from 0 to 10, and the study wanted a score of 0 to 3. Looking at a question that we received about patients with high copays. For patients with Zytiga or Xtandi prescriptions that have high copays, if the patient has a commercial insurance, we can use copay cards. Patient responsibility can get significantly dropped using these copay cards. Xtandi's card brings the copay down to $20, and Zytiga's brings it down to $10. If the patient has government insurance, we will utilize Patient Access Network or PAN for funding, and we work closely with the patients to obtain the grant, which can significantly decrease their responsibility. As a side note, patients who have no prescription coverage, we can also assist enrolling them in patient assistance programs with both medication manufacturers. Also with that question was asking about the clinical support that we provide. For each prior authorization that Avella manages out of our national distribution facility, they go through a clinical review for accuracy, which can decrease unnecessary denials. Also, with each new shipment of Zytiga or Xtandi prescriptions, the patient receives a call the day after shipment by a member of the clinical team to go over things such as dosing, adherence, monitoring, ADEs, and cancer support groups. We give them the website, phone numbers to the cancer support groups for American Cancer Society and Cancer Care, for example. Also at refill, the patients will receive a call by a specialty care coordinator, which will ask them to answer multiple questions on a survey to determine their adherence barriers or potential ADEs. Based on the patient's answers, if there's concern for adherence or ADEs, it may trigger a follow-up call with a member of the clinical team. Another question that we got was, what might predispose a patient to a seizure? So obviously, other than having a patient with history of seizures, brain tumors, stroke resulting from blockage of arteries, or alcohol or drug abuse may be other things that might predispose a patient to a seizure. We also got a question on Zometa for skeletal-related events for patients with metastatic bone disease. And yes, that can be used, and that is a product that Avella does offer for patients and that we can get assistance for. We also got another question on manufacturer assistance. So Avella will coordinate with the manufacturer, the patients, and the provider. Avella can kind of get the communication working to get the patients that patient assistance program help. But we cannot fill out the forms. Those do need to be signed by the patient and the provider. And we also do follow-up to ensure that the patient receives the medication that way. It looks as though those are the questions that we have for now. I really appreciate all of your time today. For any additional questions or follow-up, please contact me at the information provided. You can give me a call or shoot me an email with any other follow-up questions. But like I said, I really appreciate your time, and I hope you all have a great Wednesday.